thank you for joining us in this last session of the morning. Okay, so to cap off now, we've got some fantastic discussion about some cases that hopefully will reasonably common in your practice, but create a bit of a management dilemma. Okay, so this is a lady that developed an upper respiratory tract infection about 3 days earlier. Okay, and your trainees, Roland Nara, received a call from a GP, concerned GP, to say that she developed a swelling on the left side of her forehead. Okay, so Roland, what's going through your mind there?
Well, I think a forehead swelling, associated with a previous upper respiratory tract infection. What I want to do is obviously see the patient pretty soon. This is, could be a complication of sinusitis. So we'd want to take a history, we'd want to examine the patient and put an endoscope in the nose, see what's going on. And really definitively get some kind of cross-sectional imaging, if at all possible. Okay, all right. Any other differentials, or is it just you're thinking straight away that this is a sinus complication? Yeah, I mean, certainly I've been referred these as infected sebaceous cysts and skin lesions that have come up, and sometimes they can be weird and wonderfuls. But with the history of an upper respiratory tract infection, high on my differential would be a complication of sinus disease. Okay. Nara, you're concerned enough. Would you just not put a bit of local anaesthetic in and, try and take a little biopsy, or, what's your next step?
So so forgive me if my connection's sort of cutting in and out, so hopefully you can hear me okay.
Yes.
Yeah, fantastic. I mean, all the traditional ideas of approaching this externally as a straight off would be suboptimal. Your concern essentially is that you're going to end up with a fistulation or a connection. That having been said, we had a case recently, a chap who'd obviously had the sinus disease, his frontal sinus disease, present for a really very long time, and that was indicated when we tried a initial endoscopic drainage when he came in acutely, and had such thick bone that it was entirely impossible. So we did actually end up doing it by an external approach. And once actually the antibiotics kicked in and that initial abscess was drained, I must admit I was really quite worried that we were going to get this external discharging sinus. But in fact, once that all settled down, it actually healed over beautifully. And once the antibiotics kicked in, we could actually get a much better endoscopic, obviously, Lothrops in the end going through it. So
the trainees now in the audience think that a reasonable next step might be a CT scan. Would you agree?
I think presenting to you absolutely a CT scan is absolutely imperative. I think what the other thing is, forgive me, it's been mentioned already, that would be really helpful is you can get intracranial idea of any potential intracranial complications, because
we'll come on to that.
Sure.
Yeah. Okay. So what does this axial CT scan show?
So this is axial CT scan. Certainly there's a thickening of the bone around the left frontal sinus. There's loss of the anterior table integrity, and there's an opacified left frontal sinus.
So what's the eponymous name for this, Roland?
So this was likely to be a Pott's Puffy tumour, because you can see some subcutaneous swelling as well on the scalp and forehead. But yeah, so it's a complication of frontal sinusitis.
All right. Okay, so anterior table of the frontal sinus gone. Okay, but as Nara mentioned there, posterior table could go as well. So an MRI scan useful, Nara?
Absolutely, and the other thing that you can actually have perhaps a bit of a suggestion on that CT scan is the chronicity of the process, because you could see that both what remained of the anterior and the posterior table is thickened. It doesn't have that real moth-eaten appearances when actually looks like it's going to give way, but certainly you can see that osteolytic process going on both in the anterior and posterior table. So this, I suspect, will have been going on for quite some time. It's interesting to see the contralateral side relatively clear, which sometimes is and sometimes isn't the case. So yes, without a doubt, when you show that MRI, Raj, you can see that there is resultant edema around that frontal lobe, and obviously you can see
Nara,
that.
Nara, you mentioned an endoscopic approach. Okay,
Mm.
You're really skilled, right? How difficult is an endoscopic approach in an acute situation?
Very.
Why?
So I think that it tends to be the usual suspects, really. It's visibility is I would say your number one challenge. Inflamed, obviously infected tissue is inflamed tissue, and what that implies is edema, as well as almost contact bleeding. So it is very, very difficult to get good fields of view. Very often.
I've been teaching for 13 years that, don't do it. Don't do an acute approach. And then I had to about 6 months ago for a colleague's son. And it just reminded me why I don't do acute sinus endoscopic procedures. It was horrible. Yeah. So Roland, what might be an option? How would you manage this?
Well, as you said, Raj, the pressure is on to get some pus and to relieve the outflow obstruction. But you can do that. My preference would certainly be a combined approach. And I think, endoscopically, you'd want to decompress. So neuropathies are great, soaked in adrenaline, just putting up it towards the frontal recess, very, very minimalistic. This is not the time to be an endoscopic hero, do a full house fest, because you just can't with that field. But one of the adjuncts can be a balloon. A balloon can be really useful if you've got that on the shelf to, very cautiously put into the frontal recess. Sometimes the balloons have a washout feature as well. So, again, you can flush out some of that frontal sinus. But I totally agree, doing a lot of dissection in that area is nigh on impossible and will only lead to complications down the line.
Nara, if you were doing this externally, which is a perfectly good approach, what would you do?
I'd be as minimalistic as I can be is the short answer to that. We have done when I have done them when they're actually almost looking like they're discharging, I'm not a fan of trephining. I think that is relatively muscular. So I have, particularly once when it's something like that, when you know for a fact that your anterior table is gone, then actually good old fashioned sticking a needle in it and getting that pus out works incredibly well. As Roland says, it gets that decompression going very nicely. If there is some residual frontal sinus drainage, you're hopeful that combined with your antibiotics might result in some, although possibly that may not be the case if you've got almost a completely obliterated drainage pathway. But Lynch Howarth's as well would be a good other alternative. But yes, I think that would be the order. I'm not a massive fan of trephining, in all honesty.
And reasonable to come back electively once you've settled down the acute infection?
Absolutely. And I think I would go as far as saying as that would probably be my preferred way, as exactly agreeing with Roland. Get the pus out, get as much out as you can, and get some resolution of the chronic process, and then you're in a much better place to get a success, because you're going to be there for quite some time. I sound like it's easy as pie to do lothrops on these cases, but we all know that they're not. The bone is very osteotic. It is incredibly hard. You could be there drilling for absolutely hours. So you want to do that in as happy a place as you possibly can. So we've come back and done them.
Okay, thank you.
Having said that, Raj, not to disagree with Nara, but if the anterior table is intact and there's a fair amount of pus there, then a mini trephination is often quite a good idea via a medial brow incision, obviously avoiding the supraorbital, supratrochlear bundle. But yeah, mini trephination, if you've got guidance, sinus navigation, that can be useful. But Medtronic do a nice mini trephination with a cannula that you can then flush through afterwards as well. So that can also be helpful.
Okay, all right, thank you.
Thank you. Raj, sorry, it's Sean here. Can we just, there's questions from the floor or from somewhere in the country.
Yeah.
So from Victoria, she's asking, they had once had a patient who had an anterior table defect post RTA and subsequently used to get a frontal swelling each time. No evidence of osteomyelitis on the scan and was systemically well. Would you advise, and would the panel advise, prolonged IV antibiotics in such a case, or just treat the acute infection and address the frontal drainage issue further down the line?
I'll take that question just so that we can get on to the next case. Okay, so there's a problem with an obstructed drainage pathway, and each time there is either pressure caused by air or an infection, so an upper respiratory tract infection, because of that dehiscent anterior table of the frontal sinus, there's repeated swelling. So what that patient would need is to equalise that pressure gradient across the frontal recess. So either a balloon treatment or a draft 2A type of frontal sinus procedure, so that there's a better drainage pathway so that they don't get that anterior table swelling. Okay?
Thanks, Raj.
Okay, so second case. Okay, so I'm going to ask you both to focus more on the acute management, okay, rather than the rhinoplasty, septal rhinoplasty type issues later on down the line. So this is a lady who's had an injury, trauma from the left side, okay, and I'll describe some of the features there. So a depressed left nasal bone, the left upper lateral cartilage is depressed. The dorsum looks okay, so when you look on the side view, it's not too bad, but the right nasal bone, and because of the that lateralization, the upper lateral as well has been deviated towards the right, okay? So Roland, just assessment questions. If you could just, when you see this lady in the emergency clinic, what sorts of things are you focusing on?
Yeah, well, this is a classic kind of right hook trauma injury, and so certainly as you described
in Slough.
Yeah, we see a lot of it, sadly. And the nasal bone is depressed on the left, as you said, and it's taking the upper lateral with it. So first thing I would ask is, has the shape of the nose changed shape? What symptoms are you getting? But these are trickier than they look, actually.
Salient points then, what symptoms? A couple of things.
So she's going to have bruising, she's going to have swelling after the initial injury, which will hopefully all recede, so you can then assess the nose properly. I would also want to have a look in the inside of the nose, and I always counsel my juniors to look in the nose, rule out a septal haematoma in the acute setting, and then also longer term discuss with her about if she's getting recurrent bleeding, if she's getting nasal obstruction.
And CSF rhinorrhea, I guess, as well, is just making sure, particularly if it's been an injury to that sort of base of skull area. Nara, so you have decided then that you want to manipulate these nasal bones, okay? So your options then are, she's not very bruised, okay? Is either immediately or later, how much later, local, general? What are the difficulties that you're going to encounter?
So a lot of these, I think, one is the theoretical approach to this, and secondly, what are the resources? I think particularly pertinent now that we are in a COVID type era, when we have to think about what is pragmatic and what is achievable. I think trying to do it at that time under local anaesthetic is an option. What's much more commonly done is actually looking at what the, as you say, this particular picture, there isn't a considerable amount of swelling, but in instances where there is, it's incredibly difficult to assess the before and after status. and where you're trying to head to with the nose. So you'd want to see them once the swelling goes down a little bit. And on a pragmatic note, you've got to have your system set up in a way where you're able to bring these MUAs in within that 2-week period. Have done MUAs later than that and have been successful, but certainly once the 3 weeks has passed, I think you're going to find that incredibly tricky.
There's a slight Brexit preponderancy here for a local anaesthetic manipulation, okay? That left nasal bone, does it cause you any anxieties under local anaesthetic?
Well, I'm not personally myself, I don't know what Roland thinks, I'm not a huge fan necessarily, and what you will very often get with a sort of that right hook injury as like that is you will get that depression and displacement of the left dorsum, and what you very often will have to do is in order for you to manipulate any of it, you're going to have to elevate that, and you have to elevate that to a considerable degree. You almost get a sort of almost like a T-bar effect. Yeah, exactly. Yeah. So is
your patient going to be happy when you try and put a big elevator or Walshans up their nose when they're awake?
I suspect not.
No. Okay. And then Roland, in terms of stabilising that particular bone?
I mean, that's really tricky. You can put a bit of, thanks. You can put a bit of, nasal pore forte up there, soaked in something. You can, nothing will really hold it outwards from the external. So, putting a splint on or things like that just don't work. Often, sadly, you'll see that nasal bone just recollapsing over time. And, I do advise my trainees to put in something on the inside to just try and support that. But it's quite variable in terms of long-term results. I wouldn't be surprised if, we saw this lady 6 months later in Rhinology.
So the take-home messages from both of you that I'm getting is that this is not an easy local anaesthetic MUA. There are ones that are suitable, but where you have a substantial degree of deformity and you think you might need to use elevators, and it's a case to take 2 theatres under a GA with a laryngeal mask and the proper equipment available to you. Yeah. Okay.
Agree. And the other thing I'd add on to that, Raj, is every now and then, and we've all seen it, one of these tends to end up bleeding really quite a lot. Which is why I know people have different approaches, but if I could, I'd always quite like them. I don't mind them staying on the trolley. They don't have to get across to the bed, but I do like them to just humor me and will them into theatre, just in case, because 1 in 100 or something will start bleeding quite impressively. So I agree with that.
Sean, any questions there?
No questions. Just no questions, and move on to the next.
So Roland, I'm really pleased that you looked in that lady's nose, because what you actually discovered was a septal swelling. Okay, so what's going through your mind here? So how are you going to examine that to determine whether it's a haematoma or a collection?
Yeah, well, I mean, the history of trauma is a good indicator, but sometimes you can get septums that are deviated or displaced or a bit edematous. But what you really want to rule out is a septal haematoma. So again, I get all the team to perform anterior rhinoscopy, and I sometimes use a little Jobson horn or something like that, a little probe, just to palpate very gently the swelling that you see. Usually you can see it on both sides, and so it should be insensate if you palpate it and it's a haematoma or an abscess. If the patient kind of jumps back from you and it's a firm palpation, then then it's probably more likely to be a septal deviation. So that's often a good differentiator in the acute setting.
Yeah, just in time, Raj. Okay, thanks for joining us. Okay, so Nara, is it reasonable then just to give this patient antibiotics and say I'll see you in clinic in a couple of weeks' time? We'll make sure it's settled down.
That would be a fantastic way to medico-legal pathway, I suspect. Yes, it's absolutely imperative that is drained. And I think it's really important that, because on this picture, it's beautifully evident. I'd probably just say that sometimes it's not quite as obvious, and so it has to be proactively looked for and really looked for with a good headlight. So if
There
I
are
may
different-
encourage
there are
every junior.
different ways. Yeah, there are different ways to drain septal hematomas. What's your preferred, Nara? I
personally like doing this not under a local anaesthetic again. I think it's actually can be quite nice if you have the ability and you have the theatre space to do it under a general. That's personally, I fully appreciate that it can be done under local as well. That I must admit, I'm not wedded to any particular type or approach. I can see actually on the polls just popped up in front of me that there is, whether it's aspiration. I quite like actually a incision, whether it's Killian's or hemitransfixion. I don't have a huge preference on that. I don't do a septal in this, or I'm answering the questions for you, apologies. But I quite like an incision, and I will try and do a suture, like a mattress suture, and then pack. I think that's a belt and braces approach, because I think if you are in a situation where you've got septal loss, I think that's an incredibly poor outcome. So I do tend to take quite a robust approach to this.
Okay, Roland, any different? Do you use a drain?
Yeah, I mean, again, like Nara said, it depends on the patient. Obviously, in a paediatric patient, you know, a great big drain coming out of the nose.
We'll stick to adults here.
Adults, okay. So yeah, I mean, I do put a drain in if I can. I mean, the difficulty with that is, if you quilt, you must be sure not to quilt the drain in, otherwise it's difficult to get it out. You know, the key is getting all the hematoma, if there's pus there, getting all the pus out, flushing it out, and then, you know, as Nara said, quilt. I use a Vicryl Rapide or something like that, and then packing the nose just to support, again, just in the immediate post-op period, the subperichondrial flaps opposing the cartilage, because that's the key thing, is loss of...
So your belt and braces.
I am, and actually I keep the patient in for a little bit longer for IV antibiotics, you know, just to make sure you've done everything you can to save that cartilage so they don't get ischemic necrosis and then saddle nose.
Okay, all right. Sean, any questions?
No questions. Can I ask the panel, if you do find necrotic tissue, so the cartilage, do you remove it or do you leave it there?
Nara?
I think that I think you don't want to be taking stuff out. Yeah. I think if it's, the truth is, it's very difficult to tell the difference between just raggedy, has had a hematoma on it for the last however many hours, and true septal loss. I think if it's looking like it's crumbling away, I think that's why in some ways actually getting an incision as opposed to just a needle aspiration gives you that benefit, as well as just a little bit of a better view as to what is going on. I think if it's crumbling away, there's no benefit of that staying behind. But then again, we know that if we're trying to fix perforations in septal perforations rather, you know, we can put anything from cartilage, you know, external cartilage in, and actually it's amazing how much regeneration there can be. So I think, yeah. Okay. Sorry, Raj.
Raj, can I just have your nod if you agree with what Nara's just said?
Yes.
Okay?
Yeah.
All right. Okay, great. All right.
Yeah. No, I agree. Can you hear me now? Yeah.
We can. Okay. So Raj, thank you. So you've come in just at the right time. Okay. So this lady has a drippy nose, right? Allergic rhinitis or something else?
So left nostril. Okay.
Raj, what do you think? What's going through your mind?
So I would say, you know, a unilaterally drippy nose coming to an ENT clinic has to raise, the first thing coming into your mind would be, is this CSF coming out of the nose? So certainly from the referral letter, that would be first thing in my mind. And then we'd look at sort of other kind of inflammatory conditions which could cause discharge from the nose. But, you know, I'd go on to just take a careful history from her, asking about onset, any trauma, any previous surgery she may have had, and also looking
broadly, your categories are going to be what, spontaneous or some other cause for it.
Yeah. So spontaneously, she may be, you know, overweight, a classic sort of benign intracranial hypertension kind of patient. I can't remember the age of the patient. Sorry, I couldn't quite see.
53.
53, yeah. And so taking that into account, or indeed things like trauma or sort of previous surgery would certainly be the other thing.
How would you investigate that liquid coming out of the nose?
Yeah, so I mean, my normal practice here is to send that alpha tau protein, do a CT scan of the paranasal sinuses, fine cut, and use that as my initial investigation.
So how would you physically? So would you give her a pot to take away with her? What are the instructions that you give her?
So I get the patients to actually lay down in clinic, face down, hands hanging off the edge of the bed, with their head hanging off the front. I think Sean Carey gave a talk about this a few years back, and he leaves them there for about 2 minutes. So I've started to do that, and it seems to catch the patients who are going to drip, and the ones that don't drip, he seems to say they're very unlikely to have a CSF leak, unless you've got a CT scan that shows an obvious problem.
Do they have a serum test as well?
I don't. I just send them for the sample of tau protein from the nasal discharge. Okay.
Roland, do you do a blood test as well?
No, I don't actually. Again, like Raj, we've got both beta-2 transferrin and tau protein available to us. So I do a tau protein.
Okay, all right. So you look in the nose then, Roland, and that's what you see. Okay, so you've decongested the nose. That's the left nasal passage. That's the sphenoid ostium in the distance, in the middle of the screen. So you're medial to the superior turbinate and middle turbinate.
Okay. So, this is an endoscopic view, and it looks like laterally there's a kind of polypoidal area coming down from the skull base, which certainly would pique my interest as is this dehiscence in the skull base, perhaps in the posterior ethmoid region. It doesn't look like it's emanating from the sphenoids, which can be also another area commonly dehiscent.
It looks like a polyp, right? You could biopsy that. Right?
Yeah, absolutely wouldn't biopsy it now. I'd absolutely recommend that no one else would biopsy that. Otherwise, you might have very wet shoes or worse. And so, this needs to be the clinical picture needs to be put together with the cross-sectional radiology, the CT or MR. And MR actually.
So we requested an MR, Nara. Sorry, CT scan, Nara, and what that shows then is that defect exactly where Roland just said, posterior ethmoid sphenoid junction. Okay, not huge, but it's a sort of sizable thing. How would you approach managing that situation? Is it something you'd do? Is it something you'd refer over to the neurosurgeons? Would you do it?
So we would do this. So we would do this in combination sometimes with the neurosurgeons. It depends on your local setup as to who you work with, but I would suggest that a collaborative neurosurgical approach is a good one. Personally, I'm a fan of intrathecal fluorescein and identification that way. Sometimes it's incredibly easy to see your defect, and other times, obviously, you can make that collaboration between, or rather, getting that idea between what you can physically see on the endoscopic view and the CT. But I think it's still very helpful when you see that fluorescein.
And I'm sorry to put you on the spot, okay? But what's the dosage of fluorescein that you put into 10 mils of CSF or normal saline to put back in a filter?
1.
Okay, so 0.2 mils of 5 or 10% fluorescein for injection.
Yeah, that's the one. Thank you. You did your maths quickly for me. Thank you.
Otherwise known as run.
Yeah.
That's right.
In the 10 mils. So
talk through the endoscopic approaches to this, then repairing this.
Yeah. So I think very often, there is an in-between stage when you actually have to make it a bit bigger before you can actually identify it. So you'd have to have a good identification around what this, well, so-called polyp is, identify your defect. That might be quite small or it might be quite big, but it's quite nice to get an angled probe so you can identify how big that defect is. With regards to using something like either a fascia lata or a septal flap, those are good alternatives to try and plug your hole. Using things like Duraseal and Duragen are quite nice. There's different methods to trying to heal, or rather plug this hole. Some people use fat grafts as well. I haven't used that very widely, but that's also another alternative.
That would be like the wormold bath plug technique.
Yeah, exactly. But essentially what you're looking for is to almost to get an area superior to your defect that you can put your graft onto, such that the pressure that you're getting superiorly almost gives that if you have that pressure down, you've got either, whether it's your fascia lata or Duragen, you've got that nicely covered. From inferiorly, you can then reinforce that. Again, you can put another layer of whatever you like, whether artificial or a fascia lata graft, and then use some people like their Tisial or Duragen. Kind of depends on what your preferences are, and then there's different approaches to packing thereafter. Personally, I think actually packing is quite a good idea, and then obviously nursing them upright.
Sean, any questions?
No questions so far. Tunde, just missed the dosage of intrathecal fluorescein. You shouldn't have gone to the toilet, Tunde. And how long before surgery is it inserted? How long before?
I'll field that just so that we can get on to our last question. So Tunde, there are risks attached to intrathecal fluorescein injection, and that includes seizures, paralysis. Okay, so a very low dose is what you're using, and you need to make sure that it's fluorescein for injection, either 5% or 10%, not the stuff that the eye ophthalmologists use in the eye. Okay, the minims type thing, and it's 0.2 milliliters. So you have to use one of those diabetic syringes, the one milliliter diabetic syringes to get your 0.2 milliliters. Okay. Okay, Sean?
Yeah, just on that, Raj, just with the CSF preparation, for guys who do it, it needs to be prepared in a sterile environment by your pharmacy. So if you're looking on setting up that kind of service, that's the kind of challenges I faced in my service. So, but there we are.
Okay, guys, so this is hopefully the last case that we'll talk about, okay, before we break. So it's the next slide that's going to be the slide of interest. Okay, so this is a patient, this slide, who obviously has chronic rhinosinusitis with polyposis, has been treated multiply with medication, has had limited sinus surgery on a couple of occasions, polypectomies. Okay, and I want you to focus on the frontal sinus. Okay, there is frontal sinus disease there. And I was saying earlier that a measure of success in my practice is not having to revise surgery. Okay, so as sinus surgeons, okay, as rhinologists, I hope we'd all agree that we would do something. I'm not going to get into the details, but that we would do something to this frontal sinus. Okay, whether it's a draft procedure, yeah, but we are intervening in some way to aerate, but also to be able to get medication up into that frontal sinus. All right. The case I actually want you to consider is this. Okay, so patient has had medical treatment, and despite the medical treatment, still had symptoms. So went on to have a CT scan that shows ethmoid and frontal recess polypoid disease. Okay, there's a pneumatization going from the ethmoid onto the posterior table of the frontal sinus, and the symptoms are of congestion and pressure. Okay, so pressure in the forehead. Okay, Raj, how would you manage after the medical treatment?
I think clearly looking, at the scan, we've only got one slide. It's nice to look at all the sections, but I think she's got disease around where you describe, and symptoms which are refractory to medical management. One of the symptoms she's got is facial pain, and I have to say I'm quite conservative when it comes to facial pain as a symptom of CRS and managing it with surgery. So I'd be really, really careful to pick apart her pain episodes and also her the type of pain she gets, and really drill down whether that is related in respect to flares of sinusitis, whether it's sort of a baseline blockage that just worsens a little bit over the time, or really true acute episodes where she ends up with purulence, fever, unwell, which I think is quite rare, actually.
Okay, so how would you manage her then? How would you manage this situation?
So I say that,
yeah.
So I would say that you've tried a reasonable course of medication. I think there's a good chance that I'll be able to improve your congestion, and maybe if she's got smell disorder as well, that might improve with surgery. Personally,
Yeah. What are you going to do?
Yeah, in my hands, I would not actually do anything to that frontal sinus and that cell going up onto the posterior table. I would do a very good.
You do a polypectomy, uncinectomy, antrostomy, ethmoidectomy.
Yeah, I do a really good ethmoidectomy, make sure I clear frontal recess, but I wouldn't do anything more just because of the expectation level for that patient and the potential risk.
Roland, would you do anything different?
I mean, I totally agree that, after a period of good medical therapy, I think if she was really complaining of exacerbations with frontal ache, during exacerbations, and she was giving a good history, and also looking, you don't just look at the scan, you don't just look at the patient, you put them together. And if she was getting recurrent problems with that frontal sinus, and I could see outflow tract obstruction, and certainly that suprabular frontal cell is narrowing the frontal recess and drainage pathway, then I probably would deal with that. Again, very meticulous bone dissection, preserving mucosa, cutting instruments. She's got, a skull base where it looks like the anterior ethmoid artery is not hanging down on a mesentery. So, that's a slightly lower risk. So, I would have a long chat with her about the pros and cons, but in my hands, I probably would address that frontal cell.
All right. Thank you, gentlemen. And the penultimate word goes to Nara, because the final word goes to Sean. Okay, Nara, anything to add to that?
I completely agree with actually both of them as to that. This is actually a very quite difficult balance to strike, because you look at that frontal sinus and you think it actually looks okay, but you just wonder exactly what happens during infective exacerbations. And it is possible that would play up. It looks like it might be after you've done your proper uncinectomy, anterior ethmoids, and that looks like a frontal sinus balloon would be a relatively straightforward ask, although you'd have to maneuver yourself around that posterior cell, but would probably work well. So yeah,
Brilliant.
I concur.
Okay, so on that, I would like to thank my very esteemed panel and also my other speakers from the second session, so Sandeep and Tim.